Assalamu alaikum. Hope you guys are all good and very belated Eid Mubarak. Today, as you know, that we will continue the series of lecture by Dr. Naghman Zuberi. So today's our topic is occlusion. Introduction to occlusion, basically. So I would first like to invite Dr. Naghman Zuberi. Assalamu alaikum, sir. How are you?
Walaikum assalam, Eid Mubarak to everyone. And I'm good, Alhamdulillah. Hopefully, everybody is good too.
Yes, sir. Sir, you can continue from now.
Okay, okay, guys, sorry for this delay. I don't know what was the reason, maybe some problem or some technical glitches, but since we are here, so let's start now. Today, we will be discussing the most difficult topic, I must say, in dentistry. And we will start actually a series of at least three or maximum four lectures on this topic. So, today, just an introduction to this topic, which we call occlusion. Occlusion is basically coming from the English word occluded something, something which is closed. So, when the jaws are closed, the lower teeth and the upper teeth, they are in contact, so we call it occlusion. Without having the concept of occlusion, various fields of dentistry, they cannot progress, or you cannot understand the uh, basics of certain uh, fields or certain branches of dentistry, like prosthodontics, operative dentistry, then orthodontics, and even in certain fields or certain parts of oral and maxillofacial surgery, like orthognathic surgery, or even when you reduce a fracture, if you do not have the concept of occlusion, you won't be able to reduce the fracture appropriately. So let's start with the occlusion. First of all, what is occlusion? I have just mentioned that occlusion is defined as the way the teeth meet when lower jaw and the upper jaw, they are closed. And it would be any functional relationship. Normal occlusion is that occlusion where, according to Edward Engel, the molar relationship is class 1. We are not going into the detail at this time about the molar relationship, canine relationship, and incisal relationship. And there must not be any rotation, ectopic eruption, spacing, crowding, etc., etc. There must not be any proclination or retroclination of anterior teeth. Everything appears normal, and that is called a normal occlusion. Anything which deviates from the normal, that is considered as malocclusion. And there are various explanations, various relationships of malocclusion. So, for the moment, we must consider that any deviation from the normal will be considered as malocclusion. Edward Engel has given us three classes of malocclusion: class 1, class 2, and class 3. Class 2 has two divisions, div 1 and div 2, depending upon the inclination of maxillary incisors. Well, when the molars, canines, and incisors, they are in class 1 relationship, it does not mean that everything is good. There would be still chances of malocclusion in class 1 relationship because of some ectopic eruption, because of some amount of crowding, because of some spacing, maybe rotated teeth, maybe spacing only in the maxillary anteriors. It could be just procline incisors, or it could be a bimaxillary protrusion or bimaxillary prognathism. So just thinking that, okay, molar has class 1 relationship, canine has class 1 relationship, and incisor, they are in class 1 relationship. It just doesn't mean that everything is normal. We have to see other factors as well. So over here, just in this picture, you can see this is the first picture. The first relationship is class 1, where everything is aligned. I will just bring it to that position over here. With, yeah, this is the class 1. You can see incisor relationship, canine relationship, and even the facial relationship. In class 2, the upper jaw is ahead of the lower jaw, and it becomes retrognathic jaw. The lower jaw becomes retrognathic. And in class 3, lower jaw is ahead of upper jaw, and the appearance it becomes prognathic, the prognathic profile. Anterior crossbite also occurs. Anterior crossbite means when the lower incisors are ahead of upper incisors, that situation like this, that situation is known as anterior crossbite. Just to give you an idea about occlusion and different malocclusions, there are certain terms which we use during the series of lectures just to introduce you to those terms. We have already discussed about the occlusion. It is contact of opposing surfaces of teeth of both the jaws. Centric relation. It is the untranslated hinge position of mandible to maxilla. Do not get or do not become the victim of some fancy of the words. Just keep in mind very important and very like straightforward thing. Maxilla and mandible, its untranslated hinge position. Hinge position is opening and closing position of the jaws. Centric occlusion, it is occlusion of the teeth. Relation has nothing to do with teeth. Occlusion, teeth. Occlusion of teeth as the mandible closes in centric relation. This is the reference position from which all the horizontal positions, they are called eccentric positions. Disclusion or disocclusion, that is contacting of designated groups of teeth in order to disallow contact of any other groups of teeth. To understand this term or this phenomenon, bring your lower teeth, lower anterior teeth, incisors, a forward, and just bite upper and lower incisors together. You will feel that your posterior teeth, they would be disoccluded. So that is disocclusion. Like certain teeth, they are in contact, and other set of teeth or other group of teeth, that is disoccluded. For a mutually protected occlusion, which we will discuss in our next lecture, well, this disocclusion in the natural dentition, it helps. Whereas this disocclusion is not a very good phenomena when we construct the complete dentures or long span partial dentures. Why? That also we will discuss as we will move forward. Just to giving you the idea of disocclusion, how it occurs. Even in laterotrusive positions, if a person is having canine guidance, then only on the working side, the canine upper and lower, they will be in contact, and rest of the dentition will be disoccluded. Similarly, in protrusive, we have already discussed, and in canine guidance, I just explained that to you. In group function, on the working side, the posterior teeth, they will be in contact, whereas on the balancing side, teeth will be disoccluded. Now, what is this working side and non-working side? When there is a lateral movement, the orbiting condyle, that is non-working condyle, but doesn't mean that it is not working. It even works more than the working side condyle, which is called rotating condyle. I will show you the pictures. So say for instance, you are moving your jaw on the right hand side. That will be your working side. And the condyle on that side, your mandibular condyle on that side, it will be considered as working or rotating condyle. Whereas the opposite condyle, it will be considered as non-working or orbiting or orbitating condyle. So if it is left lateral side, then your left side will become working and the right side will become non-working. Over here, as I told you about the disocclusion, the anterior guidance and posterior disocclusion. When you bring your teeth in an edge to edge position anteriorly, your condyles, they translate, they move, they come out of the fossa and they come closer to the articular eminence, and that is going to produce disocclusion or separation of the posterior teeth. I have just mentioned about that. Well, over here we can see the movement in laterotrusive. Say for instance, the patient is moving towards the right hand side, the canine guidance is there. So upper and lower canines, they become in contact and rest of the dentition will be disoccluded. Similarly, in group function, the posterior teeth, they will be in contact, whereas balancing side teeth, they will be out of occlusion. Even anterior teeth should be out of occlusion. Working side, as I have mentioned, is that side on which your mandible is moving. So in this case, it is the right hand side of the patient. When the mandible, it moves from centric position in any of the laterotrusive position, so where the mandible, say for instance in this case, it is moving in this direction, and here this side is known as working side, this side is non-working side. Non-working side is also known as balancing side. Now, first of all, keep in mind very important thing, we just talk about cusp or cusps of the teeth. When we look at the cusps of the teeth, every cusp has two inclines. It has two inclines. Say for instance, it is buccal side of the tooth. This is the lingual side of the tooth. So this is the buccal incline of the buccal cusp. This is the lingual incline of the buccal cusp. Similarly, this will be the buccal incline of the lingual cusp, and this will be the lingual incline of the lingual cusp. Every tooth has two inclines in buccolingual direction. Now, when a person moves the mandible, so what is going to happen? There would be possibility. These are the working inclines. The upper buccal cusp's lingual incline is considered as the working incline, whereas the lower tooth's buccal incline of the lingual cusp will be considered as the working side inclines. On the other side, if at all there will be an interference, the interference will be on these inclines. Ideally, there must not be any interference on the balancing side. There should be separation of the teeth. So what is going to happen in that case on the balancing side? Upper lingual, this is the lingual, this is the palatal side or lingual side. So upper lingual cusp's buccal incline, because it is on the buccal side. Upper lingual cusp's buccal incline is non-working or balancing incline. Whereas on the lower tooth, the buccal cusp, this is the buccal cusp, if you remember, this is the buccal side, this is the palatal side. So lower buccal cusps, lingual incline, they will interfere with each other, and they are known as balancing inclines. As I have already mentioned that the working side condyle is known as rotating condyle. It just like, say for instance, this is the fossa, it just rotates during the laterotrusive in its fossa. Whereas non-working side condyle, it will translate and rotate as well. So doesn't mean that non-working condyle is not working. It is even working more. But teeth are coming in contact on the working side. That is why we call it working side. And where teeth are not, should not be coming in contact, that is known as non-working side or balancing side. We are talking at the moment about the natural dentition. Just a minute, let me come back to this. Yeah, so over here again, this is the rotating condyle, and this is the orbiting condyle or orbitating condyle or non-working condyle. Certain terms which we will be using during our lecture. Maximum intercuspation. That is the most closed complete interdigitation of mandibular and maxillary teeth irrespective of condyle centricity. So when the teeth, they come in maximum intercuspation or what we call the habitual occlusion, it does not mean that the condyle would be in centric relation. That is why many people, they have a shift from the centric relation where condyles will be in centricity to centric occlusion. We call it shift. Mandible, it either moves laterotrusively in a lateral direction or maybe in anterior direction to achieve the maximum intercuspation. Why it occurs, we will move forward in our series of lecture and we will see how it happens. Protrusion is the forward movement of mandible. Retrusion is the backward movement of mandible. Transtrusion is the total lateral translation or side shift of the mandible. Mediotrusion is the lateral movement towards the midline of head of orbiting or non-working condyle, whereas laterotrusion is the lateral movement that is away from midline of working condyle. Now I will go back to this picture again. This one, the working condyle, it is going into lateral protrusion away from the midline, and this one is going towards the midline, so it is in mediotrusion in any situation. If it will be on the other side, this side will become the working side, then it will go into laterotrusion, and this side will go into mediotrusion. Another very important point is ideally and what we actually produce in our complete dentures and what we produce in our very long span RPDs, the centric relation should be the centric occlusion. There must not be any shift in complete dentures. Ideally, this is the situation it should be. But in most of the people in natural dentition, there is a shift from centric relation to centric occlusion. Now, surtrusion. Surtrusion is the upward movement of only working condyle from its centric position. And detrusion, it is the downward movement of either of the condyles, no matter it is working or non-working condyles, from its centric position. Hinge axis is the imaginary line connecting rotational center of one condyle and around which mandible makes opening and closing rotational movement. Just to visualize this hinge movement, your door, when you open the door only revolves around its hinge, which is attached to the frame of door, which is confined into the wall. It cannot go here and there. It will just follow one movement, opening and closing. Or if you look at the hinge axis articulator or the plane line articulator, it only gives you opening and closing movements, and that's it. If you want, we can discuss the articulators of different types in another lecture, and we can go for that as well. Just you can always ask that, okay, we want this topic or that topic. So during these series of lecture, we can always discuss those. Now, cuspid rise or canine guidance. In this situation, on the working side, the canines, they are in contact and rest of the dentition will be disoccluded, as we have already discussed. In group function, the teeth or the posterior teeth on the working side, they will be in contact, whereas rest of the dentition will be discluded ideally. If any interference is present, we have to address to that. In order to adjust the occlusion, we have to see what is happening, why it is not letting these teeth come in contact. So because whenever there will be some interference, either these teeth will be disoccluded in the group function movement on the working side, or there would be some pain on the tooth which is having an interference. No matter it is canine guidance or it is group function, both are considered as ideal occlusions. And even at times when there is canine guidance and we go for some bridge work in the premolar or canine region, we bring the canine guidance into group function in order to have better stability, better relation. We will discuss those when we will move forward, or when a few people will ask. That is again clinically related, and why we do and how we do things, we will discuss it later. Just letting you know that at the moment, no matter it is canine guidance or it is group function, both are considered as normal occlusions without any interferences over here. No matter it is canine guidance or it is group function, only those teeth which we consider they should be in contact, they should be in contact. That's it. Ideal occlusion. An ideal occlusion should provide comfort and function in a predictable way. There are certain levels where ideal occlusion, what does it mean? The ideal occlusion at the tooth level. Here, the cusp tip to fossa or cusp to marginal ridge contact means there must not be any contact on the inclines. What does it mean? I will explain that to you. Say, for instance, this is lower and this is upper molar. If they will be in this relationship, the cusp, it is having cusp to cusp relationship. This is not considered as an ideal relationship. Ideally, what is going to happen, we should be either having a cusp fossa relationship. Here, this cusp is occluding into this fossa, and this cusp is occluding into this fossa. Or maybe if we will look at the antero-posterior relationship, certain cusps, they also occlude with the marginal ridges as well. So we will go, as we will move forward, we will discuss the 6 key of occlusion. We will discuss how that is going to happen, a tooth to tooth relationship and a tooth to two teeth relationship. We will discuss that as well. Ideal occlusion at the articulatory system level. Here, it should be posterior stability in anterior guidance. Means there will be lack of posterior interferences when person will bring teeth in an incisal relationship or incisal guidance, or upper and lower incisors, they are occluding, so posterior teeth should be out of occlusion. Ideal occlusion at the patient level means patient should be feeling comfortable without any problem, no discomfort, no pain, no clicking sound, and there must not be any what do you call it, clicking sound, as I have already mentioned, and there must not be any inflammation, any discomfort, any pain. So patient should be comfortable with that. That is the ideal occlusion at the patient level within the adaptability of the rest of the articulatory system. Anterior guidance. In lateral excursions of the mandible, working side contacts, preferably on canine. Still, we prefer canine guidance. But group function will also work. Disocclude or separate the non-working teeth instantly. In protrusive excursions, anterior teeth, they contact and they will disocclude the posterior teeth. Like this. When we will bring the person in a protrusive guidance or incisor to incisor relationship, posterior teeth should be disoccluded. And in canine guidance, rest of the dentition should be disoccluded. Posterior stability. Enough posterior teeth in each arch with solid and stable contacts in appropriate positions to evenly distribute loads and to allow the mandible to close in a reproducible centric occlusion. Basically, centric relation is the most reproducible position. Posterior teeth contact more heavily than anterior teeth. It is enhanced by tall cusps and deeper fossa. You must have noticed in some of your patients that their fossae are shallow and the cusps are shorter in height. And other patients, their cusps are very well accentuated, and you can also see in same patients the fossae are very deep. So posterior stability is achieved by taller cusps and deeper fossae. Maintains the teeth position, whether it is centric occlusion or the immediate contact position, that is easily reproduced, increased masticatory functioning with the posterior stability. When there is posterior instability or lack of posterior stability, so what is going to happen? What would be the effect on teeth? Chances of drifting, chances of phreamitis. Phreamitis is a condition when teeth are in centric occlusion, when teeth are in maximum intercuspation position, and you touch those teeth, you will still feel some movement or some mobility. That is called phreamitis. Fractured restorations, mobility of the teeth, and wear and tear facets you will see on the occlusal surface or incisal surfaces of the teeth. Those are the signs of posterior instability or lack of posterior stability. Like over here, you can see the restorations are fractured, you can see broken restorations, wear facets, etc. etc. There must be absence of any posterior interferences on the non-working side. If there is an interference on the non-working side, that should be addressed. It must not be having any interference on the non-working side. It is one of the features of ideal occlusion. Then comes centric occlusion is achieved at the centric relation position. I have already mentioned there must not be any shift from centric relation to centric. No matter it is a lateral shift or it is antero-posterior shift. The occlusal loads are axially transmitted through the teeth. Our teeth are designed by the nature in such a way that when the occlusal forces are transmitted, so they are transmitted in such a way, no matter the forces are coming from any direction, so they will be transmitted axially. Any off axial forces, they will be causing damage to the tooth and they will cause damage to the supporting structure as well. So first sign of any occlusal, we call it occlusal trauma. The first sign of any occlusal trauma, it will be mobility of the tooth. And if you will see on the radiograph, you will see widening of the periodontal ligament space. That is going to confirm, okay, the person is having some occlusal interference or some uh, like the off-axial force which is causing damage to the tooth. The supporting structure is damaged, and definitely there will be wear facets on the occlusal surfaces as well. Organization of occlusion. There are actually three recognized concepts that describe how teeth should contact in various mandibular positions. Bilateral balanced occlusion, that we try to achieve in complete dentures or in very long span RPDs. Unilateral balanced occlusion, that is group function, and the mutually protected occlusion, that is canine protected. We will discuss these three uh, you can say the concepts or these 3 points in our next lecture, inshallah. So we will meet again next Monday and we will go in detail of these 3 things, these 3 points which I have mentioned over here, and it will help you in understanding the concepts of these 3 different types of occlusions. So hopefully you have enjoyed today's lecture. I'm trying to make this lecture or this topic, the occlusion, more understandable, more friendly. I know that people, and I have receiving many students from back home, this have 2 things. Oh, occlusion, that is not my cup of tea. If it is not your cup of tea, dentistry is not your cup of tea. Believe me. Number 2, they say, oh, we never been taught occlusion in that way that we understand it. So if you do not understand the occlusion, it will be very difficult for you to understand the dentistry. So over here we will finish our lecture, our today's lecture, and then we will meet again next week. And kindly send me your questions, your queries, and all the concerns, and I will definitely address to those uh, at my uh, like most immediate uh, time available. I am available to all of you 24/7. Ahmed Nisar has asked what is the difference between centric occlusion and maximum intercuspation. Same thing. Centric occlusion is when teeth they come in contact with each other, the upper and lower. In centric relation, there will be a freeway space. But in centric occlusion, teeth they come. Same thing, Ahmed Nisar. From centric relation to centric occlusion or from centric relation to mostly the maximum intercuspation or centric occlusion, that is considered as the habitual occlusion. A person, they have a habit because of some interferences in the teeth, because of some other reason. We will come to those points later. Why these shifts they occur? Any other questions somebody has posted, Farrukh?
Uh, no, sir. Thank you, sir. It is fine, sir. I had a question because these terminologies are very similar, like a centric relation and a centric occlusion. So when
Centric
teacher asks
relation
us,
is centric relation is that situation
yes, sir.
where condyles and are present in centricity in the foci. When a person achieves centric occlusion or maximum intercuspation, then teeth will be in cusp fossa relationship irrespective of the centricity of the condyle, and that is why shift occurs. It could be lateral shift, it could be antero-posterior shift.
Okay, sir. I got it now. Yes, sir. Sir,
Thank you.
I get this. Thank you, sir, for the great lecture. I hope so. Everyone had clear the concept of occlusion so far now. Inshallah, we will continue with the next series of lectures on this topic. And next time, thank you, sir. Khuda Hafiz. Shukriya, bolo.
Allah Hafiz. Islam.